Today we're going to talk about a very, very interesting and an important discussion topic of hyponatremia. Now, hyponatremia is one group of disorder which has got a lot of endocrine issues. So what we'll be focusing today is largely in terms of the endocrine issues. And hyponatremia is one condition which, if it is diagnosed at the right time, we can manage it appropriately, we'll have a good outcome. But if we delay the diagnosis, there could be a problem. With this first case, a 14-year-old boy with drowsiness who was found to be hyponatremic, and on evaluation, the child was clinically euvolemic. The urinary sodium was done, which was found to be high. So we have hyponatremia, which is a dilute blood with a concentrated urine. So urinary sodium of 100 would mean that the osmolality would be around 400. So roughly you make it 4 times, it give you the osmolality from that regards. It was around 300 and was diagnosed as SIADH. So this is a euvolemic hyponatremia with a concentrated urine. SIADH is a reasonable diagnosis. But what happened with this child was that had a severe worsening here. And when the endocrine team was evaluated and asked for, it was found that this was actually not a case of SIADH. It was actually a case of multiple pituitary hormone deficiency. So again, before we start considering different diagnoses, so a lot of these hyponatremia will not be endocrine. But if you identify an endocrine cause, unless you treat it, there would be a problem. And this is a common situation wherein SIADH is often misdiagnosed in somebody who has a multiple pituitary hormone deficiency. And we always say that SIADH is a diagnosis of exclusion. You have to exclude cortisol deficiency, renal insufficiency, hypothyroidism, diuretic use before you make a diagnosis of that. And that was the error which happened in that situation. The other situation, again, a 16-year-old girl with abdominal pain, recurrent abdominal pain was there and now presented with seizures. So she was basically called, we were called when the sodium was found to be low. So this was a child who had euvolemic situation with hyponatremic seizures. And when we did evaluation, it found out that she was euvolemic, every other workup was normal. So this was SIADH. Now, the message again is that don't end your story with SIADH diagnosis, because SIADH is just a syndrome. You need to go at an underlying cause. Now, in this setting, we had a girl, a young girl with recurrent severe abdominal pain and seizures. So what was very important and what we got at that point of time was the urinary porphobilinogen, which was positive for porphyria. So what these two cases tell us is that don't be in a rush to diagnose SIADH, exclude the possibility of other endocrine causes which may mimic SIADH, or other causes, pathologies like porphyria becomes important. And that is why hyponatremia is a challenge. If you identify it at the right time, identify the diagnosis, the treatment will cause a very good outcome. But often there is a confusion which may happen in that regard. So all of you can go and have a look at our website, learning.growsociety.in, where there are a lot of information available about different aspects of pediatric endocrinology. We have got over a number of modules, around 100 modules, which are available along with assessment and validated tools. We got specific courses in the form of fellowship and diploma courses, along with courses for postgraduates and a specific electrolyte course as well. We run 3 grand rounds every month. So we have got this, which is a grand round, then there's a postgraduate grand round, and there's a postgraduate lecture series. And later today, we have got a postgraduate lecture series on growth hormone therapy. That's 9 p.m. later today, which you can join from that regards. There are publications, both basic and advanced, which you can access. And our mobile application, we'll also use that application to decide about how to treat hyponatremia, which will be identified in this perspective. Now, before we go into details with regards to the various causes, evaluation, and cases, we need to understand the basic homeostasis. Now, what we need to understand is that when we talk about the sodium level, the sodium concentration in the body largely depends not on your sodium, but on the free water. So sodium is a major determinant of volume, and free water is the major determinant of tonicity, that is sodium levels. So if you now think about conditions which are more common causes of hyponatremia, be it fluid overload like cardiac failure, liver disease, nephrotic syndrome, all those situations, conditions in which you have got inappropriate ADH excess or appropriate AVP excess, fluid overload is a major cause of hyponatremia. What are the conditions which are associated with sodium loss as a cause of hyponatremia? So any cause of renal or extra-renal sodium loss. So we are saying that fluid excess is a major cause, but if you're losing a lot of sodium from your gut, like diarrhea, a lot of sodium through your urine because of diuretics, tubulopathy, RTA, or RAS defect, you will have hyponatremia. But do you think there also is an issue of free water there?
Yes.
Why?
Because that water is also lost.
So, because you lose water, you will have a situation in which you will have excess production of AVP. And whenever you have excess production of AVP, your free water level will go up and you will have hyponatremia. So anybody who has got chronic hyponatremia will have an excess of vasopressin, whether it is appropriate or inappropriate. And ultimately, it is the free water excess which is the major cause of hyponatremia. Salt loss can cause that, but then body will adjust. As soon as you lose salt, body will try to develop mechanisms to do that. But if you've got too much free water, it will be very difficult from that perspective to identify and evaluate in that regards. Now, there are two ways your fluid status is assessed. One is via thirst, so how much water you are taking. And the second, of course, is how much urine you are passing. So the thirst is the main defense against hypernatremia. If your sodium goes up, you will stop your urine output, but you have to drink water to ensure that the sodium levels come down. On the other hand, if you have hyponatremia, just by stopping to drink, your hyponatremia will not be corrected. You will have to shut down with regards to the urinary concentration which is happening. You have to allow the urine to be lost, and that will be helpful. So if you talk about hyponatremia, the major defense against hyponatremia is the body's capacity to lose free water. Now, if you go other way around, the most common cause of hyponatremia would be the situations where the body cannot lose free water. And if you cannot lose free water, your free water will be more and sodium will be going down. So in a nutshell, every child who has got hyponatremia has got high AVP, has got a low level as far as the urinary loss is concerned, and the urinary concentration happens. So most cases, your urinary sodium levels would be in that setting on the higher side. While the normal response should be that the urinary sodium concentration should be low in that setting. And this is an important thing to remember from that regards. Now, in situations wherein your tone increases, now this is the other way around. If your tone increases, the hypothalamus, the circumventricular organs which are located in the organum vasculosum of lamina terminalis and subfornical organ will say, okay, now we need to get more free water in the system. What they will do in that perspective is that they will then secrete AVP, which will decrease urinary water excretion, causing increased free water. This is a normal response in the setting of somebody who is developing increased osmolality, increased tonicity, or hypernatremia. Let's put it in that perspective. Now, in a situation where volume goes down, and whenever your volume goes down, the major response comes from the renin, angiotensin, aldosterone system. And this RAS system will then do a very important thing. It will allow sodium to be resorbed along with loss of cyan. If you absorb sodium, what are going to you lose?
The potassium.
And?
The potassium and all the other positive ions.
Potassium and proton. So these two things will definitely be lost. So anybody who is having hypovolemia. So let's talk about diarrhea, let's talk about diuretic loss, let's talk about tubulopathy, let's talk about RAS defect. You will have RAS excess. Unless, of course, there is RAS defect, you can't have RAS excess. Everybody else will have RAS excess. When you have RAS excess, your potassium will come down and you will have alkalosis. So hypokalemic alkalosis is a normal response to somebody who has got a low level of sodium if the RAS axis is intact. If the RAS axis is not intact, of course, you will not lose potassium and you will not lose proton in that perspective, and that could be a problem in that regards, and you will develop a hyperkalemia and acidosis. So anybody who has hyponatremia with hyperkalemia with metabolic acidosis, you're talking about a defect right at the renin, aldosterone production, aldosterone action, and all those situations will have a problem which will happen, and that's what the RAS defect will present with. Hyponatremia, hyperkalemia, and metabolic acidosis would be the usual response in that setting. Now, as discussed, normally we say when your sodium goes down, your potassium goes up. When your sodium goes up, so in pathological causes, if your sodium goes up, your potassium goes down. So typically I said if you have hyponatremia with hyperkalemia, you're talking about largely a renin, angiotensin, aldosterone defect. What other condition will cause hyponatremia with hyperkalemia? Vibha. Hyperkalemia. So hyponatremia, hyperkalemia, renin, angiotensin, aldosterone, pseudohypoaldosteronism, CAH, all those things are there. What other condition causes hyponatremia with hyperkalemia? This is a very common condition. So we talked about adrenal problem causing hyponatremia, hyperkalemia. What else will cause hyponatremia and hyperkalemia? Diarrhea, no? Potassium sparing diuretic is the RAS axis only, na? So kidney disease, any cause of acute or chronic, not even acute also causes hyponatremia, hyperkalemia. Now, what is the difference between hyponatremia seen in a renal problem versus hyponatremia in the adrenal problem? Renal problem is because of? Fluid overload. That's a dilutional hyponatremia. While in the setting of adrenal problem, you will have hemo concentration, that is dehydration. So again, if you have hyponatremia with hyperkalemia, the first question you will ask is whether this is renal or adrenal. And this will become relevant because once we discuss this in that regards, the answer to that question is to look at hydration status. If the patient is dehydrated, this is mostly a salt wasting crisis because of an adrenal problem. If the patient is actually fluid overloaded, there is edema, it is more of a renal problem. Which biochemical parameter will tell you that the patient is having hemo concentration or hemodilution, because often volume status in young children may be difficult to assess.
And uric acid.
Yes, so uric acid and hematocrit. Why uric acid?
When the volume is more, uric acid is excreted more.
The excretion of uric acid is directly proportional to the blood volume. More the volume, more loss of uric acid, low uric acid. So if you have renal problem, unless of course the uric acid excretion is defective and that you may have hyperuricemia, or let's say if you have SIADH, in that setting your uric acid will be low because your volume is more. While if you have an adrenal pause, your uric acid will be high. So looking at hematocrit and uric acid, you will know which way to go forward. So I said hyponatremia with hyperkalemia, renal versus adrenal. What about hyponatremia and hypokalemia?
This is mainly due to tubulopathy or sir, diabetes.
So any tubular dysfunction and diarrhea. So you are losing both sodium and potassium, either through your gut or you are losing through the kidney. So you will have either diarrhea or you will have a tubulopathy, Bartter syndrome, Gentleman syndrome. You can have cystic fibrosis also. You will be losing to the sweat. So you're losing it from somewhere and that will cause a problem. So again, understanding the pathophysiology will help in that perspective. Now, if you give too much volume or your volume becomes more, the body will say, okay, I have to shed this volume. And how do it detect? It will then have a signal in the heart, because heart is where all the volume is coming. So atria, once they feel, okay, a lot of fluid is coming, we have to get rid of it. There's a specific system there, which is the atrial natriuretic peptide, which then goes on and does two major things. One is it will cause loss of sodium directly. And secondly, it will inhibit aldosterone. So any condition where the volume increases, ANP will be more. Now, what role does ANP have? Do you know of any condition which is causing hyponatremia where ANP is causing a problem? Vibha. So any condition with high volume, let's put it this way, you have cardiac failure, you have liver disease, you have renal failure, you have got SIADH. SIADH is actually a hypervolemic state. As soon as the volume goes up, ANP goes up. So ANP is the second perpetuating mechanism which is going to cause your loss of sodium. So now let's go this way. We said that you have too much free water or you have loss of sodium. That is why your sodium becomes less in that perspective. If you have got too much volume, ANP comes into the picture, that will cause more loss of sodium in that perspective. The other thing would be that if you have got less volume, then which thing will come into picture? RAS axis and AVP will come in. If you have less volume, AVP will come in, and AVP will also cause more free water. So in a way, there are two mechanisms which increase this vicious cycle of hyponatremia. One is that if you have too much volume like SIADH, your atrial natriuretic peptide will come into the picture. It will cause sodium loss. While if your volume is less and you are severely hypovolemic, I'm not talking about 2%, 5%, I'm talking about 10 to 20% dehydration, then atrial, then AVP, the vasopressin will come up, and that was going to cause you further hyponatremia. Now, the main problem with high ANP in SIADH is that if you give them sodium, what is going to happen? You say, okay, they are hyponatremic, I'll give them normal saline. What will happen then?
You can give normal saline, and because of the ANP action, sodium loss will be there.
So body is ready to lose sodium. So as soon as you give sodium chloride, it will lose all the sodium. It will, because the ANP is high and aldosterone is low. So that's a tricky situation. So if you understand this slide, you will basically understand the entire pathophysiology from that perspective, and that becomes important from that regards. Now, if we know now this much, we'll now move forward to the what could be the causes of hyponatremia. So as I said, hyponatremia is largely a free water issue. So most cases of hyponatremia are because of having too much of free water. Like hypernatremia is because of too little free water. It's just the opposite thing. So you may have more free water because of a cardiac failure, nephrotic syndrome, chronic liver disease. Those situations you will have more volume. Now here you have effective hypovolemia. There is a third space collection. Because of effective hypovolemia, your RAS axis will go up. So your potassium, you will have hypokalemia, alkalosis may happen. Your AVP will also go up. And that's why also you will have further worsening of hyponatremia, which will happen. Then, of course, if you have any reason for body to produce AVP, which is inappropriate, that is SIADH, and there are so many causes. What are the major causes of SIADH in children?
SIADH will be secondary to any infective cause.
Like
or pulmonary infection,
largely in the setting of bronchiolitis, pneumonia, meningitis, tubercular meningitis, these will be the features. But don't forget about drugs. A number of chemotherapeutic agents, vincristine, vinblastine, cyclophosphamide, ifosfamide, they will also cause a similar picture. A lot of SSRIs and substance of abuse, ecstasy, these all drugs will also cause. So these drugs, infections, these are the largely two things. And I said porphyria also as one of the causes, and mechanical ventilation, Guillain-Barré syndrome. There's so many causes, but you have to consider SIADH importantly. Very important to remember that if you have a deficiency of thyroid or cortisol, you will also have increased volume and causing hyponatremia. Now, my question to you, Vibha, is that if you have somebody who has got an isolated cortisol deficiency, what will happen to potassium? So the message is that if you have hyponatremia, even if the potassium is normal, it does not mean that you have ruled out cortisol deficiency. When there is a combined adrenocortical deficiency, both cortisol and aldosterone defect, you will have hyperkalemia, which will happen in that setting. While here your potassium levels may actually be normal or low. So look at sodium, don't just look at potassium in that perspective. The other big message is from the first case, as I said, that if you have got anybody with your diagnosing SIADH, always exclude thyroid and cortisol deficiency, because that's very, very important from that regards. Now, sodium loss can also happen, but this alone is not good enough. You will need to sustain it either via excess AVP, and that is going to cause it more worsening. This sodium loss could be a RAS defect or tubulopathy. What would be the difference in potassium levels in RAS defect versus tubulopathy?
potassium level in RAS defect will be high. It is hyperkalemia. In tubulopathy, sodium and potassium both will be low.
Okay, so very good thing to know is that if you just know potassium, you can classify that. So now how will you distinguish? Now, if we build up approach here only, it becomes very easy. If your volume is more, you are dealing, or your volume is more, you are dealing with these conditions. If your volume is normal, you're dealing with SIADH or hypothyroidism cortisol deficiency. If volume is less, you're dealing with either RAS defect or tubulopathy. There you do potassium. So all you need to know is the volume status, potassium. Maybe if you are in doubt about the volume status, look at hematocrit and uric acid and urinary sodium. These 4 or 5 tests will really tell you which is the diagnosis, how you should go ahead in terms of treatment from that regards. And of course, diuretics, cerebral salt wasting, these all factors are there, which you will know that there is a CNS insult and there is a salt wasting which is there. So hyponatremia can be because of excess free water, which is basically associated with U, or hypervolemic with a low uric acid because you have got more volume. The cause here, or sodium loss, in which you will have a hypovolemia with high uric acid in that perspective. Excess free water can be cardiac, liver, or renal in that perspective. And in this setting, your urinary sodium will be low. Why is the urinary sodium low in this setting?
Sir, again, volume deficiency.
So there is a intracellular. So it's the third space loss is there, but actual you have effective hypovolemia. So body is conserving. So you will have a urinary sodium which is low in that setting. While reduced loss is largely SIADH or cortisol deficiency, the urinary sodium here will be more than 25 in that perspective. Now, sodium loss can be extrarenal like diarrhea and cystic fibrosis, where body will then like to conserve the urinary sodium. It will be less than 25. And finally, renal loss, which can be either tubular or adrenal, where the urinary sodium will be more than 25. So if you look at 2 levels, I talked about volume, U versus hyper, and urinary sodium, you know which way you're going. If you want to distinguish tubular from RAS, look at potassium. So if you just remember this algorithm and look at volume, potassium, and urine sodium, your diagnosis is done. It's not very difficult to do in terms of hyponatremia evaluation. Now, one question which is easy to say but difficult to do in practice is it free water excess versus sodium loss? Because that's the fundamental thing. So of course, you want to look at volume, but often in small children, volume may not be very easy to say whether it is euvolemic or not. So fluid status will be one, of course, but as I said, you can use other surrogate parameters. If your uric acid is low, if hematocrit is also low, it means there is a hemodilution which is happening. While if you have got high uric acid and a high hematocrit, it goes more in favor of a concentration. So again, renal versus adrenal. This is the question which often happens. Your answer would be hematocrit. So if you have somebody who comes to you at 4 weeks of life with hyponatremia, hyperkalemia, and has a hematocrit of 68, it is unlikely to be adrenal because creatinine may be high even if it is a pre-renal failure. So that may cause a confusion. So there is hemoconcentration. It means there is a problem in the adrenals, not in the kidneys. In that reading. So main test to look at are potassium, uric acid, urinary sodium, and these ones will give you the diagnosis. So let's go one by one. Uric acid will be low if your fluid is more. So I find it very, very helpful in differentiating between SIADH and cerebral salt wasting. Now, this is a typical setting. Somebody is in the neurosurgical ICU, is developing hyponatremia. The question is it CSW versus SIADH? Now, to distinguish between the two, you can say, okay, look at the volume status. There is hypovolemia or not. You look at the level of urine output. It may be of help in that perspective or not. And the other situation would, of course, be to look at uric acid. So uric acid will be less than 4 in that setting. And I often find it less than 2, which becomes very, very easy to distinguish between these two conditions. Urinary sodium, I said, if the urinary sodium is high, it means you are losing through the urine. That is a basic cause. Potassium, if the potassium is hyponatremia with hyperkalemia, renal versus adrenal. Hyponatremia with hypokalemia, tubulopathy or GI loss. And normal may be all these SIADH, fluid overload. These conditions will give you a picture. And hemoglobin is again a marker of concentration. So hematocrit will be a good picture. So not many tests are required. Basic tests will give you the diagnosis. So look at fluid status. Of course, you have to exclude a possibility of hyperglycemia, which may cause pseudo-hyponatremia, but you will know that this patient has decay. There's no confusion. Ion selective electrodes that we are using now will not be affected by increased amount of lipid or protein. So that's not a big problem now. If fluid status is hypervolemic, you know these three conditions, cardiac, renal, and these patients you will know that there is a liver disease, and then they will have hyponatremia. They will not come the other way around. If they are euvolemic, do a thyroid and cortisol. If it's normal, it is SIADH. If it is low, it is MPHD. Work up accordingly. The issue is here, if you have hypovolemia, then urinary sodium, if it is low, it is extrarenal. If it is more, look at potassium. If there is hyponatremia with hypokalemia, think of tubulopathy and diuretic use. If there is hyponatremia and hyperkalemia, think of a RAS defect.
In this case, we had a two-month-old child who presented to us with recurrent episodes of abnormal limb movements. Coming to the present history, the child had sudden onset of abnormal movements since last 1 day, generalized in nature, associated with loss of consciousness lasting for 2 to 3 minutes each, and without regaining of consciousness in between. The mother also gives us a history of mild fever for the same duration, which was undocumented and decreased with medication. The child had no history of delayed cry or abnormal consciousness post-birth, no history of hospital admissions during the neonatal period, no history of difficult labor, no family history of epilepsy, no history of early neonatal deaths in the family during febrile episodes, no history of polyuria, and the child is not on any medication. This was his first history of illness with seizures. On examination, his pulse rate was more or less normal, had a normal blood pressure, temperature which was 99.4 degree Fahrenheit. There was no dysmorphism, no central midline defects. Again, the head circumference was appropriate for the age, had a normal weight, length again was normal. The stretched penile length in this case was 3.2, which is again normal, and there was no obvious abnormalities on systemic examination. Now, the differential diagnosis to consider at this point, due to the history of recurrent seizures, is primarily a metabolic clause, which can be a glucose problem or a calcium problem. Next, as with fever and seizures, it can be meningitis. There can be an epilepsy. And finally, there can be any underlying structural cause which might be causing the same.
So this is a very non-specific presentation.
Yes, sir.
You have to do some basic workup which will give you the further clues.
Yes. So the obvious two investigations which we all do in a child with recurrent seizures is of a glucose and of a calcium. The glucose in this case was 62 and the ionic calcium in this case was normal. The next investigations, after this we sent the whole spectrum of investigations leading, that is the complete blood count, CRPs, lumbar puncture, along with that all the other electrolytes. And this is what appeared to us was the most astonishing finding of the sodium being very low, but with the potassium being absolutely normal. So just an isolated hyponatremia in this case. Now, as Sir just mentioned, the main thing is to find out whether this is a euvolemic state or a hypovolemic state. Now, as I just mentioned the vital parameters, the child had vitals which were absolutely normal. So the next case is we went for is to check the urinary osmolality. Now, the urinary osmolality is definitely high for the level of plasma osmolality. So you have a low plasma osmolality and a high urinary osmolality.
So if your plasma osmolality is less than 270, when do you diagnose somebody with SIADH?
So a plasma osmolality less than 270 obviously will have a plasma osmolality more than 100 if you have to.
Urine osmolality should be less than 100.
So to diagnose SIADH.
So if it is more than 100, it is SIADH.
So as Sir just mentioned, if you have any confusion related to the fact whether this is a hypovolemic state or a just...
This is now SIADH.
Yes, sir.
Now, some people have confusion that this should be a CNS thing. That is why he is losing more in the urine.
So although there is no neurological input, that there is a clear-cut neurosurgery, but this again is important. If you think of any salt wasting state, that is out because of this uric acid thing.
So the next step, as Sir just mentioned, before diagnosing any case of SIDH, we had to rule out few things. Now the child wasn't on any drugs, but the other two parameters that we all need to look out is the thyroid status and the cortisol. So again, for the level of hyponatremia, which you can see on the left side of your screen of 115, the child is having a cortisol of 186. Again, it is normal, but it is very, very inappropriate for the level of hyponatremia. So this finding is very significant. So the diagnosis at this point of time is a hyponatremia due to an isolated cortisol deficiency. Now, the child was given steroids immediately after he was diagnosed as a case of cortisol deficiency. So we couldn't do a ACTH at that point of time. So the cause of this isolated cortisol deficiency hasn't been known.
But there is no pigmentation.
No pigmentation.
If it was a familial glucocorticoid deficiency, ACTH resistance, you would have much more pigmentation.
So, but the early age of presentation will the child?
They can have very early.
Okay.
At birth also.
Okay. So the management at this point of time to correct the symptomatic seizures due to hyponatremia, the child was given a hypertonic saline bolus and hydrocortisone was started at 50 milligram per meter square. Thereafter, the child gradually recovered within the next 48 hours and the child was discharged with a hydrocortisone dose of 25 milligram per meter square. He is following up with us regularly and presently on a dose of 15 milligram per meter square and is doing very well.
You can explore our books, courses, and applications. Fludrocortisone, a good drug for cerebral salt wasting? Yes. So main treatment now, this is a very debatable issue, whether the cerebral salt wasting is actually a condition or not. A lot of people debate that, but main treatment is a lot of sodium chloride and fludrocort will help in that regards. What are the reason for cortisol deficiency in this case? The MRI, I think, is normal on that. We are looking at some genetic causes as a possibility to work it up on that. We are waiting on that in that situation. There are other questions. Cutoff for mild, moderate, and severe. There is no sodium cutoff. Now, this is important to remember, Dr. Amit, that we depend upon the symptoms. We don't go by the levels because the symptoms and the presentation depends upon the rapidity of fall. So if somebody is at 120 who is having seizures, who is coning, that is severe to me. But if somebody is 115 and doesn't have that symptoms, chronic liver disease, it's not severe. So it's a combination. So if you remember that algorithm, duration and symptoms, they will give you the diagnosis and how to go forward on that. For sodium correction in hyperglycemia, 1.8 is what we usually recommend. And some 2 is also okay, but 1.8 seems more reasonable, Dr. Munir, in that.